So I thought, and I know this is all very basic, but I thought if we're going to talk about menopause and mood, let's just start off talking about menopause. So as we all know, menopause is defined retrospectively as the final menstrual period. Perimenopause is the sort of term used a lot in when we're talking about mood, menopause, and this really reflects a number of years leading up to the final menstrual period and the first 12 months afterwards. The average age of menopause in Australia is 51, with the average age of onset of perimenopause being 47. And so this, 4 or 5 year period is considered by many to be a window of vulnerability for mood dysfunction. So helpfully, the learned societies have decided to increase the number of stages of reproductive ageing in women from 5 to 10. So this is a little representation of that. And it really just shows you pretty much the same thing again. So we've got, the reproductive phase when women are having regular menstrual cycles, the menopause transition, which we just call the perimenopause, and the postmenopause. And I find this quite a helpful diagram because it really sort of re-emphasises the diagnostic criteria for all of these phases. So this is for healthy women who've not had their ovaries out and don't have polycystic ovaries. Essentially, the main way to diagnose menopause is on symptoms. So have their periods changed? Have they become more irregular, so more than 7 days between difference in cycles would really define the onset of perimenopause. And that's really enough to make the diagnosis in a woman of an appropriate age. We do have blood tests, and these are really more supportive rather than diagnostic because they can be highly variable. I think the caveat is that, we've all met women that have regular cycles until one day they don't have any cycles, so not everybody follows these patterns. In terms of symptoms, most of the studies show that hot flushes, night sweats are most likely to occur in the perimenopause and the early postmenopause, but we'll talk more about that in a minute. So this is from a really important study by Henry Berger, who's a leading endocrinologist in the area for many years and has been working at Jean Hales for many years as well. And essentially, it describes what happens to estradiol and FSH around the time of the final menstrual period. So year 0 is the final menstrual period here. And this is the onset of the perimenopause here. And what it's trying to show you, this is estradiol in a sort of schematic way, is that estradiol levels don't just gradually decline and keep declining. They're actually highly erratic in that perimenopausal phase. So as women are having ovulatory and then anovulatory cycles and possibly even ovulating twice in a cycle, they can have very high and very low estrogen levels. And that's why sometimes the symptoms are confusing because they might have breast tenderness one day, which you think, that's a symptom of estrogen excess, and then they're having hot flushes. And it's also why often the symptoms are highly intermittent and irregular, and you ask them, how often you're having hot flushes, and it's a bit of a difficult question to answer because they might have a phase where perhaps they haven't ovulated and they've had very low estrogen levels and they're getting severe symptoms, and then they're fine for a few months. So it can be very irregular. After the final menstrual period, you see quite a significant and steady decline over the first couple of years, and then the levels tend to even out. And this is what you often see with menopausal symptoms, that they're quite bad around this time when the levels are erratic or dropping significantly, and then as the levels even out, it seems to improve. And of course, the inverse happens for FSH. So this is from the same study. This is looking at hormone levels in a single woman leading up to the menopause transition. So up here is, the time before her final menstrual period. And this is from a study where they got women to do monthly urine samples and just have a look at, daily samples and have a look. And you've got her FSH up here and her estradiol up here. So if we just look at her estrogen, 1 month she's got extremely low estrogen levels. But then over here, all of a sudden it's much higher, it's got a huge peak up here. It's basically all over the shop. So that's why, it's can be a very erratic time for symptoms. And we think that this changing levels and the erratic nature of the oestrogen levels is partly why there is this vulnerability to mood symptoms. So there was a very large study published in the BMJ a few years ago looking at a British cohort of women, and they found that on average through this time frame, so around 1 in 3 women had experienced severe psychological symptoms at some point, and 1 in 4 had severe physical symptoms. Now you can't say that that's all the menopause, but it probably contributes to some of that. The classic menopausal symptoms we all know about are hot flushes and night sweats, which tend to be the thing that women usually present for. Vaginal dryness, sleep disturbance, headache is very common, and often joint aches and pains. Mood changes are something that, again, we're finding is more common, but has been only really recognised or researched in depth in more recent years. In terms of the duration of menopausal symptoms, most of the work of this has been around the vasomotor symptoms. So there was a very large study published in JAMA recently, which was a longitudinal study of American women, the study of women's health across the nation. And they tracked women every year for multiple years. And they found that, for most women, hot flushes and night sweats last around 7 years, or around 4.5 years after the final menstrual period. But they persist a lot longer in quite a significant number of women. So this is a graph from that study. So if we just focus on A here. So this is the study of women's health across the nation, and what they've done is tracked how long women had symptoms based on when they developed the symptoms. So were they premenopausal, were they the early perimenopause, the late perimenopause, or the postmenopause. This green line in the middle here tracks the percentage of women who were overall, looking at all the groups, who were still experiencing hot flushes, and this is the number of years after the final menstrual period. So if you look at women overall, 14 years after the final menstrual period, you've still got about 40% of women experiencing some hot flushes. Now, not all of them are going to have severe or bothersome symptoms, but it's still, I think, a much higher proportion than what we'd thought in the past. And if you look at these poor women who started getting symptoms when they were premenopausal, by about 12 years out, you're still looking at about 80%. So it looks like the earlier your symptoms start, the longer they go for. This is part of a study that I've been involved with, which is a survey of 2,000 women around Australia who were between 40 and 65. And we asked them about their hot flushes and night sweats. And this is their age along here. And in black is the percentage of women who are having moderate to severe hot flushes. So as you'd expect, it peaks in the early to mid-50s. But we were finding that even in women in their 60s, quite a significant proportion of them, somewhere between 5 and 10%, are still experiencing moderate to severely bothersome hot flushes, which again was more than we would expect. And the same thing is what we found for night sweats as well. So, it's a common problem for women, and it does tend to last a long time. What about mood symptoms at menopause? I think there's been quite a debate in the literature about the significance of mood symptoms at menopause. The overall take-home message really is that for women without a history of anxiety, if we look at anxiety first of all, that they're twice as likely to develop anxiety in the perimenopause and the early postmenopause compared to when they were premenopausal. And I think in the clinic, often this is a very common thing to see. Anxiety's not being closely looked at in terms of the menopause. There's been a lot more focus on depression, but certainly in the clinic, anxiety is a very common picture that people present with, and it may be that they've had anxiety in the past and it seems to have been triggered for some reason at this time, or that they just seem to have de novo anxiety. You're not necessarily talking about anxiety disorders, but often people just report feeling more anxious. The other thing that women commonly report is that things that didn't used to bother them, for some reason now they find stressful. And that's a very common complaint as well. In terms of depression, there's been more studies into this. Most of the research has looked at depressive symptoms rather than depressive disorders per se. And women seem to be around 2 to 4 times more likely to feel depressed during the menopause transition than when they were premenopausal. The risk is much higher for women who've already had a diagnosis of depression, that they seem to be more likely to have a relapse at that time. I put this in, it's not a great slide, but it took me ages to make it, so that's why this one's in here. We did a review looking at studies that examine the association between hot flushes and feeling depressed. So in the green on top there, we look at cross-sectional studies. And in the bottom there, we're looking at cohort studies. So studies that followed women for a long time, who took women with hot flushes and said, what's the chance you're going to get depressed? And overall, there does seem to be, all the studies tend to favour an association that women who have hot flushes are more likely to be depressed than women without hot flushes. And that women who have hot flushes now but aren't depressed are more likely to develop depression than women whose hot flushes have resolved or who don't have hot flushes. This is quite a nice slide from the BMJ study, looking at profiles of psychological symptoms in relation to the menopause. So the main one I'll draw your attention to is this bottom slide. So again, 0 here is the final menstrual period, and this was tracking their depressive symptoms leading up to the final menstrual period and the years afterwards. And it's quite nice the way they've analysed it, because they've shown there's different groups of women with different symptom patterns. So, there's a lot of women who really have basically no psychological symptoms, and they just stay that way through the whole time. Some women who have a moderate degree of symptoms, and again, that seems quite stable. But then you've got around 10% of women who fall into this group, who seem to have this increase in psychological distress leading up to the final menstrual period that then does seem to improve with time, the further they get from their final menstrual period. And that's what I think a lot of the studies are reflecting, is this group here that has, there seems to be some connection between menopause and this spike in depressive symptoms. The women who start off quite depressed already, they do seem to get a bit worse, but then they just seem to stay bad. So this is looking at women in our study, so the 2,000 women across Australia, and we grouped them into perimenopausal, the younger postmenopausal women, so equating to early menopause, and older postmenopausal women. And we got them to fill out a Beck depression inventory and looked at the women who had moderate to severe depressive symptoms, so a Beck score of more than 20. And again, it followed a very similar pattern, where the sort of early postmenopause, there was a much higher range of women reporting moderate or mild depressive symptoms. And then by the time women were more than 55, it was pretty much back to the premenopausal level. With this same data, we then had a look at whether, this was likely to be related to menopause, or was it related to other factors. And we were able to show that, this association with depression and anxiety did seem to be related to their menopausal status, even when you take into account a whole lot of other things about the person, like their age, their body mass index, whether they're caring for someone in the family with special needs, whether they're married or not, whether they're in paid employment, whether they feel able to pay they're securing their housing, whether they've had mental illness, all these sort of things. So even after controlling for multiple factors, this association seems to be maintained. In these women, we also looked at alcohol, smoking and psychotropic use. So what we were trying to have a look at is, well, they have this spike in symptoms measured by a scale, but is that actually clinically important? Is it being shown in any other way in their life? And what was quite interesting is that there seems to be this little spike in binge drinking. So this was having at least 4 drinks on one occasion, at least once a week. That seemed to spike up this time. There seemed to be a little spike in smoking. And the use of psychotropic medication seemed to increase at that time as well. And so there were statistically significant differences between the menopausal groups. So it looks like they were, this wasn't just a blip on some epidemiological measurement scale, but that it's actually having an impact. And we did the same thing, so we accounted for all of the same factors again, and it did seem to be a real association. And interestingly, when we looked at psychotropic use by menopausal status, it looked like, again, these women in the early post-menopause were the number of women using benzodiazepines seemed to spike as well. So it looks like the anxiety is a bit of an issue. There was an increase in antidepressant use, but it wasn't nearly as great, and it wasn't statistically significant. So the research tells us that mood symptoms usually improve after the menopause transition. So once you get fully through the hormonal changes and things have settled down and you've got nice even hormone levels again, that mood symptoms tend to settle and go back to the way they were before the menopause transition. The caveat to that is that it can take a really long time for that to happen depending on the woman. We've got some evidence that hormone therapy might improve depressive symptoms and anxiety, but many women find they get side effects from hormone therapy as well, particularly from progestins. So it's really not an easy area. So being an endocrinologist, I prescribe a lot of hormone therapy, and really its main indication is for the treatment of hot flushes. There's no approved indication for the use of mood disorders or mood symptoms, although there's some evidence that it may improve things in perimenopausal women. And as you know, oestrogen is the most effective treatment for hot flushes, and it comes in a variety of different formulations, but it has to be matched with a progestin in women who have a uterus. And the real percentage of women who are affected by progestins is not well known. I found one study suggesting 30%. I'm not sure that that's really the case in all the people we see in clinic, but there certainly are a subgroup of women who seem to find that when you add in the progestin, they just feel more irritable. And they're not brilliant drugs. So you're all familiar with all of these, so I don't need to show you that one. So hormone therapy obviously is a contentious issue, and it's become very difficult because there's so many analyses and reanalyses, and is it safe and is it not safe? And a lot of the time in clinic is spent discussing the risks and the benefits and all this sort of thing. So I've tried to compile what are sort of some of the latest information about the risks of hormone therapy. A lot of it depends who you're using it in and what you're using it for. So in terms of, everyone's worried about breast cancer. I mean, it's not the thing that's increased the most, but that's what all women are worried about. So we know that if you're using combined oestrogen and progestin therapy, the risk is increased after 2 years. So these results are all from the Women's Health Initiative, which was the very large study published in 2002 that randomised women either to conjugated equine estrogens plus medroxyprogesterone or placebo, and another arm of women who'd had hysterectomies who were randomised to conjugated equine estrogens only versus placebo. So their overall results, and these are sort of the recently published results, were that yes, combined therapy does increase breast cancer risk, and this is maintained even after stopping the treatment. The risk increases after about 2 years. The hazard ratio was given for 5 years of therapy, which was about 1.24. So it really depends, I think, on what your baseline risk is. So that can be difficult to calculate as well. I mean, if you've got a very strong family history, et cetera, your baseline risk might be already substantially elevated. And that's why often it's difficult to work out. For most women, their baseline risk is probably somewhere around 3 to 4% in a lifetime, rather than the often quoted, 1 in 11 or 1 in 12. So I think it's got to be looked at in context, and women have to be aware of what the risks are. And if you're having a 20% increase on top of a 3% increase, that's a lot different if you're having a 20% increase on top of a 10% increase. So it's very much an individual thing. I think it's often compared to the risks for that associated with excessive alcohol use, which a lot of women in the clinic are having anyway. So that often puts it in perspective as well. The other risks we know about are stroke and DVT, but no change in all-cause mortality. Interestingly, in the Women's Health Initiative, oestrogen-only therapy seemed to possibly decrease the risk of breast cancer. Now, whether that's a class effect or a conjugated equine estrogen effect, I think is not clear. This again is just looking at the same data where they've broken down the two studies, so the combined therapy and the estrogen-only therapy by age. It's a bit hard to see, so I'll just say that the risks are clearly quite different for women who are in their 70s compared to women who are in their 50s. And part of that's perhaps the timing of initiation in relation to menopause, but also the baseline risks these women are starting with. This is looking at risks in terms of the change in case number per 1,000 women per 5 years of treatment in women aged 50 to 59. So this is a bit more of a concrete way to look at it, and it's more likely to be the women that you actually would be using hormone therapy in. So essentially, there's really not an impact on all-cause mortality. There's really not an impact on heart disease, so we're not using it for prevention of heart disease. And then we see this increase in breast cancer. So 6.8 extra cases for every 1,000 women that use combined hormone therapy for 5 years. An extra 5 cases of DVT or PE, an extra 1 case of stroke, 5 less cases of fracture, a lot more cases of gallbladder disease. So I think it's complex, but often the absolute risks are not anywhere near as bad as what people imagine in their minds. When we're talking about mood, often antidepressants come into it, and often are very appropriately used and very important. SNRIs are often prescribed in this context because of their benefit on vasomotor symptoms. And I'm certainly not against antidepressants. I think some of the issues we've come across with problems are, weaning people on and off. You all know this more than me anyway. Tachyphylaxis with things like venlafaxine, hypertension with venlafaxine. So there was a recent study looking at treatment of hot flushes with low-dose venlafaxine. It was quite low dose, and around 10% of women had to stop it for hypertension. And there's some emerging data about possible increased risk of fracture as well, but that's still not clear. So I think that why I put this slide up is that, I think when women come in and they want hormone therapy, we worry a lot about the risks, but part of the reason is that we have great data about the risks, whereas we don't have a lot of data about a lot of other medications to the same extent. What about more specifically with mental illnesses? So there's increasing data about the effect of menopause in specific disorders. We know that in epidemiological studies there's often a blip in diagnosis of psychiatric disorders in women in their early 50s, and often admissions to psychiatric hospitals, etc. For women with bipolar disorder, it's been reported that they're more likely to have a relapse of depressive symptoms at this time, and that maybe hormone therapy is protected. For women with schizophrenia, there may be, again, a dip in mood, and recurrence of depressive disorders is also often a bit more common as well. So that's the menopause section. I've got some more about mood in the menstrual cycle and premenstrual type symptoms, and the reason I've put that in is that often these symptoms recur or get worse when women are in their 40s and heading towards menopause. So often, they're still having regular cycles, or their cycles are becoming irregular, and they'll come in saying that they've got PMS for the first time, or it's much worse than it's ever been. And I think it's all part of the same spectrum, really. So when women describe PMS, I guess there's a few different things that we think about. Is it PMS? Is it premenstrual dysphoric disorder, which is the more crippling version? Or is it that it's a cyclical exacerbation of an underlying psychiatric disorder, which is also very common? And just so we're all on the same page, we just described day 1 as the first day of bleeding. And the premenstrual symptoms usually occur in the 5 days leading up to the bleed. So symptoms usually occurring in that week or two beforehand. I think it's important not to over-pathologise as well. It's very normal for most women to notice some changes. It's when it becomes disruptive that it's important. So PMS is when those symptoms are more intrusive, whether they're physical or emotional symptoms. And I think we all know the symptoms. So fatigue is by far the most common symptom, and it can be, quite very severe symptoms. Irritability, bloating is very common, anxiety is a very common thing, cravings are very common, low mood, and there's a whole bunch of symptoms. Interestingly, in some of the studies, the symptom that's really differentiated PMS from depressive disorder has been aching. That women with PMS often find they get quite achy muscles and things in that week as well, which is an interesting finding and maybe connects to the increase in inflammatory markers seen in that time too. But it's very poorly understood syndrome at this point. So PMDD is really the sharp end of the wedge. So it's that 5 to 10% of women of reproductive age who have very severe symptoms. It's been defined in DSM-4 and 5. So they have to have 5 of the following symptoms, one of which has to be depression, irritability, anxiety, or affective lability. And there's a whole range of other symptoms such as feeling out of control, insomnia, breast swelling, and it has to interfere with their usual activities. The key part of the diagnosis is that it's cyclical, so the symptoms occur in the luteal phase and then remit within a few days of the bleed starting, and they have at least a symptom-free week sometime in the follicular phase. And ideally the diagnosis requires a 2-month daily symptom diary. There's really no specific tests. When I see these women in clinic, I will look, you want to exclude other underlying disorders which perhaps make your general health a bit worse, thyroid in particular, and you're really probing for other mood disorders and other things that might contribute to it. So a lot of women that I see who present with this picture will have had early childhood trauma, and that clearly contributes in a significant way. The cause is really not well understood. Clearly with the cyclicity there has to be a hormonal component, There aren't any hormonal differences between women with PMDD and women without PMDD. So it's not a hormone disorder per se. What seems to be different is the way the brain is reacting to these hormones. Most of the research is focused on progesterone and its particular metabolite called allopregnanolone, which I'll show you in a second. There's also been finding of an increase in inflammatory markers in the luteal phase, which correlate with the affective and physical symptoms. And that's sort of a newer pathway of research as well. So allopregnanolone is a little is here. It's a metabolite of progesterone that requires 2 enzymes to get down that pathway. This is just showing physiological allopregnanolone levels. So as you'd expect, for example, in pregnancy, as progesterone levels rise, so do allopregnanolone levels. Throughout the menstrual cycle, you'll have very low levels in the follicular phase, and then there'll be a peak in the luteal phase. So the current theory of several is that women with PMDD have a paradoxical response to allopregnanolone. So in a similar way that around 5% of people have a bad reaction to Valium and get irritable and aggressive with Valium, this works in a very similar way on the same receptors, and that maybe 5% of women are reacting with irritability and in a bad way to allopregnanolone. And that it seems to be that if you've got very low or very high levels of allopregnanolone, it seems to not have as much of an effect, but for some reason with luteal phase levels, there's this paradoxical reaction. So this is a theory at this point, but there are medications being developed to try and affect this pathway. In the US, they're looking at it in a different way. So what they've taken is a medication called dutasteride, which actually blocks the conversion of progesterone to allopregnanolone. And this just shows with the use of the medication you have decreased allopregnanolone levels. And they found that did in fact reduce the mood symptoms. So it looks like allopregnanolone has some role. I think it's still unclear about exactly how it works. But it seems to be that the GABA receptors are not responding in the same way for some reason. It's often, because it's ill-defined and poorly researched, often women end up on this little roundabout going through like every naturopath you've ever heard of and every multiple different ways of treating it. In terms of what has been shown to work, although various things have been suggested, there's really no evidence, there's no research looking at whether any of these things really help. I think exercise makes sense because we know it helps depression anyway. We know that alcohol use is associated with worse PMDD, so I think being sensible about that is good as well. And a lot of women find that if they're having regular symptoms and they plan their life around that a bit, that can help as well. Most women that I see have tried all of these things, and I think there's one study looking at chasteberry, which had some effect. Really what we end up left with is the oral contraceptive pill, so trying to block ovulation and avoid that rise in allopregnanolone. That works in some, but again, there's some women that just seem to react very badly to the pill. And antidepressants seem to be quite effective in some women, and the way I talk about it in clinic is that it helps the brain respond or react to the hormones better. It seems to work much faster in these conditions than in depression itself. So in one of the big RCTs in Sweden, they found that irritability scores improved within 14 hours of dosing rather than needing 4 to 6 weeks to have a symptom improvement. And you can use the antidepressants cyclically, so from mid-cycle onwards, rather than having them every day, although that's generally not as effective as having it every day. We've done a bit of work looking at the pill as well. So a lot of women I see come in trying to find a pill that suits them. And it's often really difficult. I think the pill just doesn't suit everyone, although it's a really good drug in many other ways. There's a fairly high discontinuation rate due to mood side effects, and as we've discussed, progestins can worsen mood in a subgroup of women. This is from a very small study, so it's only 100 women, we haven't published it yet, but we looked at healthy women in the community and asked them what pill they were on and asked them about whether they had depressive or anxiety disorders. So it's very early research, but it seemed to show that, you know, women on your standard pills, this was the percentage with anxiety issues, and it seemed to spike in women on drospirenone-containing pills. And that's something we've seen in the clinic as well, where the sort of Yasmin type products seem to, in some women, seem to cause more mood issues. But then again, you know, I know you'll have all seen plenty of women in clinic who tolerate it really well, and it's very good for them. Again, we looked at women and compared their depression scores based on how much oestrogen they were having in the pill. And I should say, I mean, even though the low group had the high depression score, this is still not in the depressed range. So although more oestrogen seems better, I mean, these women were still not depressed. But it was just an interesting finding. So I often get asked about, well, how do you pick a pill? And I think it's really difficult, particularly with, you know, only a limited number on the PBS. When I see women who have particular mood issues, so depression, anxiety, I tend to stick with the ones that have estradiol in them as opposed to ethinyl estradiol. So I like Zoli in particular. Not particularly evidence-based, I should say that, but I've found it pretty good. And I tend to avoid the Yaz and Yasmin in these particular women, not saying you should never use them. So I guess to finish off, the thing that I commonly get asked by women in the clinic is they feel really bad, their mood's bad, they've got anxiety, and they say, is it my hormones? And I think it's not a simple answer. So usually I say, well, it's probably a bit of everything. I think your hormones, if you're in the perimenopause, it's likely that it's providing a bit of vulnerability, but that's usually in the context of other things as well. So often when you find women in the menopause clinic who are having a really difficult time with mood and with hormonal symptoms, there's often a lot of other stress going on as well, and I think it's really important that all that's addressed properly as well. And often, you know, it needs to be tackled from multiple different aspects. So whether it's the lifestyle thing, since seeing, you know, the results of our study, I make sure I religiously ask everyone about alcohol and smoking now, and which obviously we should anyway, but it's surprising the number of women that have recently retaken up smoking, or their drinking has gotten out of control because they're trying to help manage their anxiety. We refer to psychologists a lot. Sometimes hormone therapy is helpful and sometimes antidepressants are needed.